Hello everybody, my name's Anthony Brown. I'm the Executive Director of Health Consumers New South Wales, and I'd like to welcome you to our briefing on Navigating Telehealth, the patient's perspective. Before we go any further, I'd also like to acknowledge the traditional owners of the various Aboriginal lands that we're all meeting on today. I'm on Gadigal land, and I'd like to pay my respects to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people who are joining us today. So in April 2021, Health Consumers New South Wales released 2 reports around telehealth and patients' perspectives and thoughts on telehealth. The first document you can see here is a summary of the key things that patients and families told us, and the background document goes into more details about the history and the sort of policy background and around telehealth in New South Wales and Australia. And I'd encourage people, if you haven't seen them already, to please download and have a look at these documents. The next slide, please. So Health Consumers New South Wales was becoming increasingly concerned that the experience that patients and families have of using telehealth services wasn't being talked about and wasn't being involved in the public discussions around telehealth, particularly as telehealth was used and evolved in response to COVID-19. And we were also really concerned that health consumers and consumer representatives hadn't been involved as much as we believe they could in the discussions and the forums that were developing telehealth services and virtual care. And we really wanted to continue to remind services around the importance of having health consumer representatives around the table while those decisions were being made. And as part of that, we wanted to remind various stakeholders and the people making these decisions of the importance of involving health consumers now in these discussions, particularly as we look to design what telehealth services are going to look like post-COVID. So, yeah, next slide, please. So what do we mean when we're talking about telehealth? Well, quickly became apparent as we looked around, there were a lot of definitions, but we're talking about healthcare services that are delivered at a distance, and that distance could be across geography, could be delivered at different times, and across different social or cultural distances, if there are social or cultural reasons why people may not be able to be in the same room as their practitioners during a consultation. Consultations that involved information or communications technology. We limited the scope to what we talked about to virtual consultations between clinicians and patients and families. And given the timing of this work throughout 2020, it's not surprising that most people were talking to us about their experience of GP consultations. And we spoke to people mainly in New South Wales, but we also heard from people outside of New South Wales. And obviously, because of the range of experiences people were talking to us about, from GP consultations to also hospital consultations, we realised that there's the policy implications for this work cuts across jurisdictions, and some things fall within the Commonwealth and some things within New South Wales Health, within New South Wales. So what did we do? Well, in April 2020, Health Consumers New South Wales formed the COVID Consumer Leaders Taskforce, which were representatives of health consumer leaders from across New South Wales who had a lot of experience working within and for health services, and also had quite strong community and patient networks. And that group really helped guide our response to COVID-19 during 2020, and they were assisted in that work by the consumer organisations Taskforce that we formed at the same time. So the Consumer Leaders Taskforce identified telehealth as one of the top 2 priorities for consumers during COVID. The first priority was around visiting policy, and I encourage people to go back and look at our report and briefing on that topic. And during February to November 2020, we'd heard a lot about people's experience of telehealth. So initially that was anecdotal and what people were telling us, just often in relation to other things. But we held a series of workshops and surveys and a virtual workshop in August 2020 to ask people about telehealth and what was important to them and what were some of the ways that we could improve it, and where were times when they thought telehealth perhaps wasn't suitable for them, as well as the good experiences. We talked to consumer and community group representatives through both the Taskforce and other networks, and we also looked at what responses and issues people had raised around telehealth on the Care Opinion website. So the next slide, please. So this timing, obviously telehealth has been around and has been in use before COVID-19, and in 2015 the New South Wales Strategic Review noted that telehealth usage did vary across local health districts and facilities, and that there was a lack of integration across various platforms for telehealth. Telehealth was prioritised in the 2019-20 strategic plan for New South Wales Health, and there was an investment in the infrastructure and attempts to build some more consistency, starting sort of highlighted in that plan. And also in February 2020, the Royal Prince Alfred Hospital started its virtual care and virtual hospital, which has since grown during COVID-19. And so we were in a place where, particularly in New South Wales, we had services that were using and were quite well prepared telehealth, and were able to adapt quite quickly during the pandemic. So what people actually told us about their experience of telehealth, I'll actually turn to my colleague Layla Hallam. Layla is the co-chair of the Consumer Leaders Taskforce, and also one of the co-authors of the report. And I'll ask Layla now to go through and let us know the key themes that consumers told us around their experiences. So over to you, Layla.
Thank you, Anthony, and hello, everybody. One of the things that we realised right up front was the fact that we had different ideas of what telehealth consultation actually looked like. So when we went through to see what we were talking about when we talked about telehealth consultations, the first thing we looked at was the MBS data, which was, of course, the most accessible public information. And what we found was telephone ruled over video. So even though we talk a lot about video, in fact, it was telephone that ruled during the COVID period and since. GPs, for instance, 97% of their consultations were by telephone, while 3% were by video. I think the specialists were doing a little bit better, with 30% of specialists actually using video. But nonetheless, when you're listening to this feedback, I think it's fair to say that the majority was what we're talking about is by telephone, although it does also cover some video. We also found that while there was a lot of talk about telehealth and not being able to see your GP, in fact, face-to-face still ruled over telehealth, even at the peak of COVID. So even at the in April, May, when COVID was probably at its highest in terms of not knowing what to expect, telehealth still was only about 25% of all consultations. So that means 75% was still face-to-face. And of course, as Anthony mentioned, most patient exposure came through GPs, and this reflects how people actually do use healthcare. So the bulk of it is coming through GPs, and there's the dip in and out of the specialists and the hospitals, and this came through in the feedback that we received also. So what patients and families said: for some patients, telehealth was a game changer. And that led us to look at, well, who was saying that? And what we found was, of course, it was very clear that rural, regional and remote, people living in rural, regional and remote were going to have the most benefit. And I think we've known that for years. But what we also found was people with physical impairments who struggled to get up steps to go and visit, for instance, their clinician, could also struggle for a consultation. And suddenly telehealth made things easier for them. People who rely on other people, so people who have to have support people coordinated and involved in order to get to their appointments, suddenly it freed them up also. And people with chronic life-limiting or life-threatening conditions, amongst a range of others, who really didn't have time to waste travelling and sitting in waiting rooms unnecessarily. So the big thing that we heard was, in fact, telehealth was a game changer for a lot more people than I think we probably realised. And so what did that mean? It meant that they actually improved their access to healthcare. There was less struggle and less pain. People spoke about how difficult it is for some people to actually get to an appointment in terms of the pain and, you know, how difficult it is to actually physically get there. So we had lots of feedback talking about, you know, making it much easier to access the care because they weren't cancelling appointments because they couldn't get there. There was also other feedback came back about the unnecessary risk of mixing with other ill patients. And bearing in mind, a lot of our cohorts of frequent users of our health system are ill themselves. And so not wanting to jeopardise their own health by sitting in waiting rooms where other people are also ill came out very strongly. And then, of course, there was the big one, which was about minimising lost time, income, and including of support families. So that really is about the travel time, about the waiting time, about, for some people, how difficult getting to appointments can be and how much time it takes out of their lives. We talked about more, they also, as well as being more accessible, people also talked about it being more efficient. And again, the big one was minimising time wasted, and for some people lost income. So to take time off work to actually attend an appointment in itself is not a big deal. However, when it's happening over and over again in a month, it then starts to accumulate, and people were finding that they were eating into their holidays in order to get to their consultation appointments. And then once that was gone through, often they were unpaid to get to their appointments. So time wasted was a very big one, and all the ramifications from that. It was a more timely service. People spoke about the fact that for some people, having access to a specialist, they jumped, the waiting list just wasn't there. So during COVID, from the time that they were referred to their specialist, the time they got in, it was almost negligible. And this, of course, is very different to our regular referral time periods. And of course, waiting rooms was probably the big one. Whereas for some people, going to a consultation, sitting in a waiting room and waiting for the clinician is just part of the course of a consultation. But suddenly when we talked about a 2 o'clock appointment with a clinician, we actually meant a 2 o'clock appointment with a clinician. It wasn't the check-in time that some of us are more used to. And that was a really big one that people found. And of course there was a degree of it that was also forced, because if you're sitting on the other end of a telephone line and there is nothing happening, at least when you're in a waiting room, you have the queue of people sitting around you, so you know what's going on. Whereas when you're on the telephone, you don't have those queues. So people were expecting that their calls were being answered very promptly. Other people spoke about focused consultations. It seemed to focus the mind. A telephone call seemed to focus the mind, and the issues were dealt with more quickly and, for some people, better. And that sort of leads us to the in and out when that's all was needed. So here people were talking about if they just needed a referral, or if it was just a repeat script. Things that ordinarily could take a couple of hours now were just done in 5 minutes. And others, and in addition to that, we also found that telehealth made care more equitable. So people who had sought care who may otherwise would not have. So these are the people who, in order to get to the consultation, required too big a burden, or the cost was just too high for them to get there, so they would not. So there is a cohort of our people who do not seek healthcare because it's just too hard. Suddenly telehealth made that far easier. And there was a brief time in March and April while the specialist consultations were free, and people were glowing about that. There were people who had never been able to afford a specialist appointment suddenly were not only referred, but were able to access the service at no cost. That has since changed, but for the brief time that it was on, it was a big deal for some people. The message that came out very clearly was that patients want telehealth, but they want it with conditions. They want telehealth as long as care is not compromised. It doesn't change. What they want is still safe, effective care that's sensitive to patient needs. They want contingencies built in so that they seamlessly dip in and out between telehealth and face-to-face when necessary. So to give you an example, we had a case where one of the orthopedic clinics had actually gone online, which was what was needed at the time. But there was a child with a cast, and the cast was loose, and the parent was, prior to the appointment, the parent was trying to explain that they thought that there was something wrong with the cast. But instead they were put through to telehealth. That was fine. They went through the and in fact, in the orthopedic clinic, it happened to be a video consultation, which was great. But what that did is the child was able to demonstrate that the cast was loose. And of course, as soon as they realised that it had to be a face-to-face consultation in order to fix the cast. But the care wasn't seamless. So what happened was, not only did they have to go through the telehealth process, but then they had to go through an emergency, back into an emergency department, where they sat there for 4 hours waiting for the cast to be done. So this is talking about the fact that, you know, telehealth is fantastic, but when we need to move into, for whatever reason, back into face-to-face, then we need to find ways to be able to seamlessly. And it's worth saying here, and it's the other way around. So when we are having face-to-face, if we don't need it, being able to seamlessly move into telehealth was also noted as something people wanted. And patients want choice. So not only do they want uncompromised care, they also don't want to be forced to use telehealth if their preference is face-to-face. So if they're more comfortable to use face-to-face, then making them feel forced that is no longer available to them is something that we heard very loudly. There was no doubt a fear that people felt that bringing telehealth was going to mean that face-to-face services were going to then be made unavailable. So even whether that was true or not, that's what patients were particularly concerned about. So even those patients who loved telehealth were still reticent, because they were concerned if it came at the cost of the face-to-face. So choice became very important. And of course, not being forced to use face-to-face where the preference is telehealth. So that speaks to the status quo. So now people having a taste for telehealth, not wanting to be forced back into face-to-face unnecessarily if our clinicians decided that telehealth was no longer a priority. So choice came through loud and clear. Essentially, they were saying that they wanted both options made available and accessible. So going through the process, telehealth was seriously a fantastic win. However, patients want it to sit alongside face-to-face. They want both options available. There is no choice, for instance, if in fact one is at the expense of the other. And that goes for face-to-face at the expense of telehealth or telehealth at the expense of face-to-face. We spoke about integrating with face-to-face, the example of the child with the loose cast. So that's the dipping in between face-to-face and telehealth. But in addition to that, it's also about moving across from the telephone to video as well. So the telephone, the next step is the video, the next step, of course, is face-to-face. There is much more that we can do and see when we can see people, of course, and the video provides a next step to the telephone. So there were comments coming through to say, look, it was fantastic, but we'd really like it if we can do it on video as well. We spoke about the smooth transitions with integrating face-to-face and telehealth, so they can dip in and out as necessary. And people also wanted to talk about transparent protocols for clinicians and patients so that patients could actually have an understanding of, if we spoke about inappropriate, clinically inappropriate decisions that required face-to-face, people understood what those parameters were. So there was this idea of transparency and understanding how decisions were being made if in fact patients weren't being given a choice because it might have been deemed clinically inappropriate. So it's about the right delivery mode for each patient and their circumstances. This also reflects the patient's desire to be able to dip into telehealth if actually it's being suggested that that they require face-to-face, but it's not for necessarily clinical reasons. So understanding those protocols is important. From a baseline perspective, when we talk about telehealth, people absolutely want telehealth to work. So the enthusiasm for telehealth was also about people's understanding of the technology, whether it was available to them, whether it was actually accessible to them, and whether it was easy to use. So here we're talking about hardware. Do people actually have the hardware that's required? Do they have access to the Wi-Fi, and how easy was it? From a technology perspective, we're talking about phone and video options built into the process. So we're actually stepping in and working towards video options as well as telephone. So it's the right mode for the right service that's being delivered. They spoke about platform consistency across health settings. So yeah, fantastic for one hospital to do it in a particular way, or one clinic to do it in a particular way. But if all the clinics are doing it differently, and then of course, if all the GPs then, so our primary care is then doing it differently again, what we're doing is we're putting the onus on the patient to actually be the one who is continually learning and adapting to the different technologies. So consistency came up as being pretty important, and particularly when we understand that most people are going to access telehealth through their GPs. So having that line between, okay, I'm fine on having my telehealth appointment through my GP, and being able to transfer that confidence across into different care settings is important. We also talked about making sure that the technology and the processes are inclusive. And so that includes for all people, those with poor English, those with physical impairments, or anyone who's simply not so confident with technology. So that, of course, is very much about access for all. In addition to technology, the next level up is making sure the process was right. So yes, I can get the technology to work, but the next step is, how did the process go? So catering to patient needs is important. And here we're talking about, as we mentioned, sitting on the end of a phone line and waiting when there's actually no idea of what's happening next. That just doesn't work. So catering to patient needs is important when we are developing those processes. It needs to work for the patient's end. Selecting face-to-face or virtual, so understanding the processes. So that goes back to the transparency, but also the process. How are those processes determined, and understanding that that patient needs may well be different to clinician needs, and making sure that that's built in. Appointment setting and appointment keeping. Yes, how do we make the appointments and how prompt are those appointments? Did it work? So if we said we had a 2 o'clock appointment, did we get a 2 o'clock appointment? If it was a 2:30 appointment, was that still okay? The time and cost expectations. So making sure this was actually a really interesting one, because this is where people's assumptions started to come into play. Some people actually equated telehealth with being a shorter consultation. And sometimes this was being reinforced by their clinicians, often a GP. So this is actually speaking to, well, what are the expectations that we want telehealth to fill? Are we saying that they are the shorter expectations, or are we saying that we're expecting them to be equivalent where appropriate to a face-to-face appointment? So being clear on that is very important. And there was the idea of costs. So even though we were having telehealth consultations, some people were receiving bills at the end of them without realizing that they were. And I think that also spoke to this idea of it being a lesser consultation, and therefore they were not expecting a cost, even though if they had a face-to-face appointment, they may well have been billed for that separately. The idea of privacy, that links up firstly to setting expectations of how to do that, but also about appointment keeping, in fact. So what we had is let's go back to that 2 o'clock appointment, and in fact the GP finding, or the GP or the clinician finding some time prior to the 2 o'clock and giving the patient a call at 1 o'clock and the patient's still in the supermarket. It didn't work. So it may have filled the gap for the clinician, but it didn't work for the patient. So it's just making sure that we understand there are implications for timekeeping that go beyond sitting in a waiting room. Then there was also a suggestion of it would be great to have a record of the interaction. So just understanding, okay, this is what we talked about, and this was the outcome of the consultation, was seen as something that was really helpful. Time spent waiting, we've spoken about that, but these are age-old chestnuts. These are things that if we go into a face-to-face appointment in a clinic or a waiting room, chances are we're going to be waiting. Telehealth actually gave us an opportunity to relook at that, because people weren't prepared to sit on the end of a line for a long period of time. So in fact, telehealth actually allowed us to really look at some age-old chestnuts. The time spent waiting was just the first. It also allowed us to look at coordinated integrated patient care. Suddenly, technology and telehealth, but particularly the technology, became an enabler. So instead of patients having to have multiple clinical appointments, technology allowed those appointments to come together. So not only were you able to virtually have one appointment with multiple clinicians, but in fact, it also aided coordination of the care. So everybody was hearing the same thing, and of course, communication. Because we were hearing all the same things, and because there was an opportunity to work across specialties, there's the opportunity to really crack the nut of the silos that can occur when people have multiple specialties that they're working across. It also, that same logic worked in healthcare settings as well. So, you know, involving the GP in specialist consultations, technology enables that to happen now. And being able, the GP, to be better informed as to why we're going in a particular, also into a particular direction with the specialist, then also helped the patient receive a more holistic and better coordinated care. So working across healthcare settings, primary to specialty, to specialists and to hospital now, and also to home. Suddenly we've opened up how technology has allowed us, excuse me, to be able to work across settings. And of course, it also opened the door to involving families. Many families, many patients want families to be involved, but it's difficult, you know. So this actually allowed families to get involved where the patient wants them, and particularly during those those critical junctures where somebody might be receiving a diagnosis, where somebody's treatment might have to change because it's not working, where somebody is receiving care or receiving news that's hard to handle, patients can be enormously supportive in those instances, and being able to make it much more easy for family to be involved. Many patients spoke about the huge benefit that allowed them. Of course, yes, connecting, including and involving families and patients and clinical teams across care settings. So this actually spoke to the idea, particularly during COVID, where patients were coming into hospitals and in order to protect against COVID, visitors weren't invited into the hospitals, and so patients were feeling isolated and alone. So firstly, the first thing that the technology did, of course, was enable families and patients to stay connected, even though they were physically apart. But then it also allowed them to consider how families could also be involved, for instance, in things like ward rounds. So when clinicians were coming around, in the traditional world or the status quo world, we have families who are sitting by the bedside waiting, sometimes all day, just for the clinician to come around doing their daily rounds so that everybody could understand what was happening. And we heard so many stories previously about, you know, somebody would get up and go get a coffee and suddenly the clinicians would be coming around and they would have missed it. This changes that. This actually allows us to think about, well, how can we how can we use technologies to support families to be involved and included, and not necessarily have to have them sitting there waiting all day. So it connects patients and families, it connects patients with clinicians, but it also connects patients and families and clinicians into the care, and that makes for better care. Patients and consumers also spoke about building better. The fact that we had many people come in with ideas on how things could be, and indicating that they wanted to be part of the how we come back and build better. So patients, consumer stakeholders want to partner. So what that means is that consumer reps actually support patients, make sure they have a voice when we're designing new services or even refining services. So that's about talking about embedding continual consumer feedback and partner with consumer reps. So the continual consumer feedback is part of our improvement and our continual learning. So as patients are using the services, continually asking them what worked and what could be improved, then goes into working out from a system perspective and a process perspective how we could better cater to their needs and listen to their feedback. And of course, the partnering with consumer representatives, as mentioned, they are the voices of the patients around the table when we are designing processes, policies to achieve service outcomes that deliver for all stakeholders. So partnership came up as very important. So to sum up, there was a resounding support for patients wanting telehealth to bring people and services together. It was very clear telehealth was very supported by its patient base, and they saw it as a huge opportunity to, in fact, maybe do things a little bit differently and to do things better. So to bring people and services together. And as we spoke about, it's about improving coordinated and integrated services across multiple clinician services and healthcare settings. Now, this won't happen by itself. Telehealth alone won't solve it, but telehealth gives us the opportunity to reconsider how we might be able to do it better. And connecting patients and families together and into clinical services and discussions, as we spoke about. So telehealth gives us the opportunity to bring people and services together if we design it appropriately. When we're talking about bringing people together, we're talking about coordinating clinicians within specialties. We're talking about coordinating clinicians across specialties. We're talking about integrating clinicians across healthcare settings and connecting patients with families and family members in clinical consultations. It was resounding. Patients want telehealth to stay post-COVID. People wanted to hear that telehealth was being committed to the future, that people wanted telehealth to be committed to post-COVID. But they want it universally available. They want it free of the MBS constraints that were in place pre-COVID. They want it available to all patients. They wanted it for all clinical and services and across all healthcare settings. Now, that doesn't mean that where it's clinically inappropriate, that patients want that. But what they do want is to make sure that the rule is about clinical inappropriateness rather than the system dictating who could access the service and which services they could access. So this is about people want us to strive for equitable care. It came out very loudly. So universal access for the purposes of equitable care. They want us to design for optimal care. So integrate telehealth with face-to-face. So just understanding that telehealth in itself is not a new model of care. It's in fact just a different way of delivering care. And so this is about making sure that people are receiving the best possible care, regardless of whether it's through telehealth or whether it's face-to-face. It became very clear that confidence became really important as an accept. If people were to accept this as to use it for themselves, we needed to boost the confidence of service consumers and providers. So that meant that we had providers who were confident and willing to use the technology, and then of course supporting consumers to also to build their confidence. So at the end of the day, we're talking about building better, using technology, using this line in the sand to build better. Consumer stakeholders want to partner to embed continual consumer feedback so that we're continually learning what our patients need and how the services can be continually improved for their care, and to partner with consumer representatives to address these needs and deliver great patient care at a system and process level. That's it, Anthony. I'd like to open it up now, pass it back to you, but any thoughts, welcome to hear them.
Thank you so much, Layla, for going through and bringing out the key points that people told us around the use of telehealth. The really important things for Health Consumers New South Wales is that this work and investigating what patient and family experience of telehealth has to continue. And we'd really like to see more work being done to hear from patients about their experiences and to bring that patient experience and consumer representatives into those discussions around improving telehealth, involving consumer representatives and also consumer organisations where appropriate. In the design and redevelopment of telehealth as we go forward and as we continue to use telehealth post-COVID, which is something we all want, as Layla said, where it's clinically appropriate. So again, thank you, Layla. Thank you everybody for joining us today. Please go to our websites to download the copies of these reports, and I'd encourage you all to please to read those reports to get all of the details. And please contact Health Consumers New South Wales if you'd like somebody to talk to your group or your committee about this work. So thank you all for joining us, and yeah, we hope you have a good rest of the day. Thank you. There's been a few comments and questions that have come through in the chat, and really one of the things that around the issue of privacy was raised, and especially about the question of how can we be assured that the clinician is also in a private space, which wasn't something I think that people raised, but it's a really important consideration, because I'm sure a lot of clinicians used this as an opportunity to also do some work from home. So I'm just wondering if you've got any comments about that.
Privacy did actually. So privacy, in the feedback that we got, it came through specifically about making sure that people were able to have these conversations in a private setting. There was also, from a patient perspective, being able to do it at home. So not simply in a supermarket in a crowded place, but actually being able to do it at home. Some people did find that problematic because there are other family members in the house. So the issue of privacy is something that we do need to work through as we go to work out how that works. And because the other side of that coin was that we had patients who wanted family members to be involved. So really, it's a question of making sure, I think what patients were saying, they just want to know that their information is safe. And when they want information to be shared, let's say with their family members or with other clinicians, that they are in a position to also be able to do
that. That's fantastic. Thanks, thanks, Layla, and raising that really important issue about not just privacy, but that it means different things for different people. We've had a couple of comments and questions around access and who could or couldn't access the telehealth, and if there were any comments from different groups who had particular difficulties around telehealth. I mean, I do remember that some people told us that people with cognitive impairments and people with some physical disabilities did have problems actually using the technology. But I was wondering if you've got any comments you'd like to add to that, Layla.
Yeah, there definitely was a number of different. Look, I'm a bit loath to speak about groups because some people were able to navigate and some people struggled. But certainly from a disability perspective, so visually impaired or hearing, there were definitely issues. There were also issues for people who don't speak English, so non-English speaking background. So certainly they also struggled but bearing in mind, we're a work in progress. And I think, I'm sorry to go all over the place, but access was there was a lot of different stuff about access. And at the base of it was technology. So whether we're talking about socioeconomic groups who didn't have access to Wi-Fi or didn't necessarily have access to the hardware and the software, for them, access of telehealth was near impossible. But there are ways to come around that. And for instance, bringing them into a public, and I don't mean a public space like a supermarket, but I do mean into maybe a clinical care setting where they can have a room and they have everything set up. So there are opportunities to do things better, but access definitely came out. If we don't get the processes right and make sure that we're actually catering to the needs of all the different people who we want to, who should be able to, who should have telehealth as an option available to them, that's our work in progress. That is actually how we move on. So those areas certainly did arise.
Okay, no, thanks. Thanks, Layla. We've also, Rani's also talked about in the chat the convenience that telehealth has offered her as a wheelchair user. And so I think that's something that was also picked up in other discussions we've had.
Sorry, yes, if I can just add to that. And that was one of the big boosts of telehealth. Suddenly people who couldn't access, who struggled, so not couldn't, but certainly struggled to access physical impairments amongst a range of other things. Suddenly telehealth made their life so much easier. But again, we're not talking about, we're not saying that telehealth is the answer every time. We're just saying that at the right time, when people should be able to make those choices, to be able to make things easier for them when it's the right situation for them.
Yeah. No, thanks. And this is a really interesting question from Jonathan around, if there were any concerns expressed about the technical security around the telehealth consultation. And Leila, from my memory, there wasn't in the discussions we had, which I must admit was a surprise to me. Have I remembered that correctly?
You have. No, there was nothing. I think, I think privacy is a really interesting thing. I think the bottom line is nobody mentioned technology security. And that's because I think most people have already gotten used to sharing information over their phones. So they do it already on a day-to-day level, and they might share personal information with their family members. And I think that that's just an extension of that. But no, we did not have anybody come back and talk about security from the technology or the concern about it.
Yeah. So sorry, Leila, was that? I was just wondering. I'm just aware of time, and we've had a couple of other important discussions. One's come through about the new telehealth sort of conditions that have been foreshadowed by the Commonwealth Government. Now, obviously, the conversations we had with people happened before these announcements, but that it looks like telehealth consultations, aren't going to be allowed under Medicare if they're longer than 20 minutes. And just, any thoughts on that?
Yes, I think people will see that as problematic. I think that where it's clinically appropriate, so where there isn't a physical need to be seen, there are people who struggle with getting to a face-to-face appointment. I suspect, just by the tone of what people were saying, was that really it should be open to the clinician and the patient to work out what is the right mode to deliver that consultation. So I think putting artificial barriers is probably not going to be so well received. But I preface that also by saying it is hugely, we have made such huge strides from what telehealth was in the past from an MBS perspective, and we definitely don't want to go back to the way it was defined prior to COVID. And I think this is where patients and clinicians really need to come together and work out whether that's a good move or not. I think that's an open discussion that needs to be had.
Yeah, no, thanks. Thanks, Leila. And an important question from Carol about if we received any specific feedback from Aboriginal populations. We only had a very small number of responses from people who identified as Aboriginal or Torres Strait Islander in our surveys. And we did reach out and had some informal conversations with some of the community-controlled organisations, but it was quite limited in what we were able to do in the time. Leila, do you have any comments on that?
The only thing that I'd say is, yes, there was a limitation with how many people. So there's only so much that we really can say about as a group about bringing that information together. But what I will say is that autonomy, and that's about choice, that was important across our patient base. And autonomy, being able to have the consultation done in a way that suits the person, is one of the things that shone through. And we also know that that's one of the things that our Aboriginal and Torres Strait Islander brothers and sisters also want. So I would just take us back to, having patients as partners will help us navigate what's right for each individual group.
No, thanks, Leila. And I also want to emphasise that this Our motivation to do this was because we couldn't find any examples of where people had been talking to patients. So we reached out and asked primarily our members and other people to let us know about their experience. So I think there's a real need for some more concerted work to work with a whole lot of different populations and different groups in our community to find out what telehealth means to them and what works and doesn't work for them. I think we've uncovered some good general principles, but we know we need to talk more with a whole range of different groups to find out what this means for them and what's important to them.
Can I just take that one step further?
Please.
One of the reasons, as Anthony's just mentioned, was that there was no publicly available feedback that we could actually look at or harness, so that as consumer reps we could build a position on telehealth. And rather than rely necessarily on individual opinions, this is exactly why we went out and we asked people to come together and tell us what they thought. That probably the beauty of this is that within the LHDs, who have done some fabulous work in these spaces, they also will have feedback that they will have received from their patients. So particularly the qualitative feedback. And within that qualitative feedback, the journey now is to look at where it aligns and what we can learn from all of that, so that we are all in a position to do it better. So it's essentially lifting us all up rather than necessarily having pockets of beautiful expertise. So I would just really urge all of you who have come from an LHD where you have access to your feedback, have a look at it and see how it's similar or different, or where the gaps are, that we can then build from, and make sure that we do have patients being very clear with what's important to them about telehealth and what we need to know to make sure we get it right for them.
Right. No, absolutely. Thank you. Thank you, Layla. I'm aware of time, and we do want to wrap up at 1 o'clock. So we'll just take one more question from the chat, and then we'll wrap up. And that was a question from Meredith about the different platforms and the different ways people connected up. Layla's already talked about the fact that connecting to doctors by telephone was the way that most people connected over the past year. But Layla, any reflections or any on what people said about the different ways of connecting with doctors?
There was definitely some chat from an experience perspective specific to telephone and specific to video. But if I can just step back from that, because there's also literature about that and the benefits. So if we think about, it's almost a stepped approach. Telehealth will be, telephone will be fine for some consultations. Video will be better for other consultations, and then face-to-face will be better for other consultations. But what came out quite clearly in our patient feedback was that a lot of the time we hear about, look, it's not about the technology. And whilst it is not about the technology, we have to get the technology right if telehealth is going to work. And what I mean by that is that we have, if people cannot access the software, the hardware and the Wi-Fi, then they actually can't get it at all. The next step is, if people can't make it work, or they don't have the confidence. So we had some people who were quite computer literate who still didn't want to use telehealth because they felt they were intimidated by the technology. So making sure that the technology is, that we are able to explain the technology in ways that are simple for people to absorb and feel confident about. And again, I suspect that will also apply to our clinicians as well. And then going to the heart of the question that was just asked by Meredith was the consistency across different places, the consistency for patients across different health settings. So we get patients who learn how to do it in one health setting, U-Beauty, and they're excited and hey, they've mastered it. And then they have to go into another health setting and now there's another thing that they have to learn, different technology, different platform, different processes. And I think that's where we're going to stumble with our patients if all the learning emphasis is actually on them each time. So the technology platform and the consistency across wherever they are in their healthcare setting, so whether it's primary care or secondary or tertiary, trying to make it as consistent and as simple will be something that will be a key to how willing patients are to continue to embrace telehealth. They just don't want it hard.
No, absolutely. So look, thank you so much, Layla. There's been some really fantastic discussions continuing in the chat. Well, I'm sorry for the people whose questions we didn't get to, but consider them taken on notice and we'll do our best to get back to you. I want to thank Layla, not just for her time today and going through all of this, but the work that she's put in beforehand to bring this together with Serena. I'd invite people, if you haven't seen it already, you can download the report. I've just put a link to the report in the chat function. We'll also send that link out to everybody who's joined the teleconference, who registered. We'll add the slides from the presentation. They'll also be put up on that website soon. So thank you all for that. And also, if people would like a representative from Health Consumers New South Wales to talk to your group, to your committee, or to other groups or networks that you're involved in about this telehealth report and the results, we'd be very happy to do that. Please get in touch with me or send us an email at info@hcnsw.org.au, and we'll do our very best to provide somebody who can talk about the slides. And whether that's a 5-minute slot or an hour slot, we'll try and work in with the group or the committee that you're involved in. So again, thank you all very much. We're coming up to the hour. I can see Julia's popped in the correct email address, so thank you, Julia. So is there anything else you'd like to finish with, Layla?
No, I just think that this was a fabulous opportunity for consumer reps to actually listen to our patients and their experiences, be able to learn from it, and in turn also be able to support our system to make sure we get telehealth working as well as we can. So thanks everyone for listening.
Yep, no, fantastic. Thank you all, and we really appreciate your time. We know everybody's busy, so thank you all for your interest, and we'll be in touch shortly. So thanks and goodbye.